Hello, good evening, everyone. Can anyone hear me? This is Dr. Khan from Executive Plastic Surgery. Again, this is Dr. Khan from Executive Plastic Surgery. If you could please comment and let me know if you can hear me. Okay, that's great. So Happy New Year to everyone, and looking forward to a very exciting and very inviting year 2020. There is a lot to discuss. Hopefully this will be the year that we will make the biggest impact and the change, and hopefully to educate the potential patients so that we can understand this phenomenon, this disease, which is not well described and looked at and studied and researched, the breast implant illness and how it affects to the millions of women who have had breast implants, who many do not are aware of the signs, symptoms, the illnesses, the subtle ways it presents itself, and how it continues to evade us, and how it continues to basically hide, and basically it has all what the pattern recognition allows us, so that despite all the labs and imaging, we see the patients one after another who continue to bounce back and recover and basically heal after explantation. I actually was wanting to get a guest on, one of my patients who I operated on just yesterday, a very nice lady. She was the second case of the three cases that I had done yesterday, and she had explanted, and when I did talk to her this morning, she had expressed to me that her brain fog had improved dramatically, and also her back pain had also improved significantly. And unfortunately, because of technical issues and reasons, from what I understand, dual our guests to come on live, we will proceed on having her be in my office on Monday, and she will come on live with me as a guest, so that we can basically see her on the floor under her first post-operative visit. Now, a lot of questions over the break that I did get in regards to how and what are the different thoughts and processes in regards to what is a not studied breast implant illness, and what is the best way to treat it. One thing I want to start off again, and this is the gist of the conversation today, which is that the capsule needs to be removed definitively. It is imperative. I put a post out a few hours ago. As you can see, this was one of the questions that were asked. Whenever I remove the implant and the capsule as one system, which is the end block, I send the capsule off to the pathologist so that they can evaluate, look, they polarize the light. And in this case, as you will see, they did document that the polarizable light was consistent with silica. So this is the shell that is essentially formed on an implant that was very much intact. And that basically signifies or proves to us that there is silica within the capsule itself, and hence the significance and importance of removing the capsule, because there are many surgeons amongst us, plastic surgeons, who basically claim it's okay to leave 10, 15, 20%. It's not imperative to remove the entire capsule, and that just removing the implant is sufficient, which is absolutely not the case. Otherwise, as you can see in the pathology report, one is leaving behind the capsule, plus the impurities and the toxicities that it carries, along with the heavy metals and the silica that continues to mount this immune response. And this is essentially the take-home message. You do not want to remove 90% of the capsule, because that 10% that remains continues to mount that immune response, continues to haunt the patient, and continues to burden the patient, so that when the patient does bounce back, they bounce back only a fraction of the time, which is certainly not what is the desired goal. You do not want to remove part of it, but absolutely you want to remove 100% of it. So as you can see, that is hard evidence that the silica within the capsule needs to be removed in its entirety. And this is the whole take-home message. What I find very disturbing and what I find very disheartening and wrong is where you see the explant surgeons who claim to be explant surgeons across the country, and we know because of the way the surgery is done that the capsule remains behind, even though that the explant surgeon claims that he's going to remove the capsule. And this is ultimately dictated by 5 different ways that one can at least keep a tab, not only on the explant surgeons, but also on me and every single person. So at least I say that one can say with definitive certainty that the surgery was done right. The first thing is looking at the length of the incision, making sure that the incision is at least 9, 10, 11, whatever centimeters, which is going to be the width of the implant plus the capsule, because you cannot remove the end block implant plus a capsule from a 2 or 3 centimeter. You have to have it wide enough such that, as you have seen on my YouTube videos, that the entire implant plus the capsule is delivered through a nice length so that there is no potential for rupture as the implant is being removed. Number 2, the length of time that the surgery takes is not an hour or 2. I have heard repeatedly, even over the break, reputable surgeons who claim to be explant specialists who are taking 2 hours, not only to do an end block, but also to do a lift. And this is what I've heard from other patients who have expressed. And I will tell you from my experience of having done this, it is a very impossible. It is literally not achievable a goal. Otherwise, I would want to learn that technique. I would want to know how just the lift alone takes a couple of hours at least, if not more, and an end block to be done right. And this is where the nice tedious dissection off of the chest wall and underneath the pectoralis needs to be done, such that the entire capsule is removed, such that there is no burden that's left behind. So number 2, the length of time that the surgeon takes needs to be around 4 hours. So like I was saying yesterday, I did 3 explants. I didn't finish and leave till 8 p.m., 7:30 or so, and that the entire day was spent just doing 3 explants. I did not try to rush it. Had I left the capsule behind, certainly I would have done it in a much faster fashion. And the entire gist and challenge of the surgery is to be able to tease and remove the capsule off of the chest wall such that I actually remove the fascia off the intercostals, off of the rib, and also off of the intercostal muscles, such that there is bare muscle that's left behind. And that's the level of tedious dissection. Otherwise, I find that you're leaving the capsule behind. It is not sufficient alone to burn or cauterize or bovie the capsule, because I find that you leave the residual silica behind, and that small amount continues to burden and harm the patient. Over the break, I also did hear that some surgeons were actually using the argon beam, which I find fascinating. This is not ideal to be taking a flame type of a burn, which we use in liver sections, for example, to basically remove, because you're essentially not removing, you're essentially burning the silica, which essentially remains and continues to harm. So you have to physically remove the capsule off. So going back to the review of 5 things how you know your explant surgeon has done the surgery right. Number 1, the length of the incision needs to be good 9, 10, 11, 12 centimeters. Number 2, the length of time is critical. I find that's a nice way to gauge, to see the way that the surgery was done right. And this allows for the surgeon to very meticulously dissect off of the chest wall such that the blood loss is minimal and such that the drains ultimately need not be placed. Number 3, you want to get pictures not only of the implants, but also very importantly, I find that you'd want to get a picture off of the chest wall so that the surgeon has taken a picture of the chest itself to document very clearly that the capsule has been removed. so that is the ultimate proof that the entire capsule along the entire diameter and circumference and the volume of the implant has been removed. Number 4, you want to go ahead and get the implants back, which is certainly very safe if given in a biohazard bag or container, which is ultimately also proof that the implant, be it saline, that was not ruptured and that was removed intact, and that essentially is the property of the patient, and there is no harm in giving it to the patient for these were in the patient's body, and there is no harm in having them in a sealed container. Number 5, I find, which is critical, that the reputation of the surgeon is also key. That, just like me, there is a lot of talk, cross-talk between patients, groups, and an understanding of who and what. Because after some time, we all know what is going on, how is the surgeon operating, what are the results like, what are the different levels of commitment that the surgeon has into regards to believing what is breast implant illness. And the ultimate proof that one has that one is a board certified plastic surgeon who is a believer in breast implant illness is the surgeon who does not put in implants and he explants only. And we're slowly starting to see a conversion, at least of 3 or 2 docs that I know, at least in 2019, who were initially implanting and also explanting, and now who have chosen to explant only, which is a good change for the better, so that we can at least accept the fact that this badness is not occurring, at least from their hands, and that when they're explanting, these surgeons are committed to truly 100% removing the capsule in its entirety, because they believe in breast implant illness so wholeheartedly that they're not putting in the implants. So you can see in the eyes of Dr. Feng, for example, and I've mentioned Dr. Chun out of Los Angeles, California. These docs, they truly have been the good role models, the senior surgeons who have committed themselves into establishing, and you can accept their faithfulness and sincerity into removing the implants with the capsules and block, or a total capsulectomy, which is 100% removal of the capsule in a very safe and a standardized way, so that when you go to these patients, you know you're taken care of. Whenever I see my patients, I always tell my patients when I see them, are you feeling better? No. I always ask them, how are you feeling better? Because I know with absolute certainty that the capsule was removed in its entirety. Now, one of the questions that I did get asked earlier was, when do I see my patients post-op? I give my cell phone number to all my patients, for I want them to be in touch with me literally 24/7 whenever there is an emergency, or there is ever a need, or there is a problem. Like one of my patients ended up having, and we know the realities of any surgery, having a yeast infection, for example, from the antibiotics that I'd given her. I don't want her to go to her PCP or call in the morning, or go to the emergency room where they have to wait 5 to 7 hours only to be seen, just so that they can get a tablet for diflucan. I can listen if I need to see them emergently. My doors are always open, where my patients just call Jennifer or my office, and they just literally get plugged in the same day so I can see them. But I have a standardized, I don't want to see them the next day unless there is a problem. If I want to see them, I see them in the middle of the night, because they have a direct link to me. I want to see them at least physically, if everything is going well, day 5, 6, 7, or day 4, depending on when and what day I do the surgery. Because I'm not going to remove the dressing or the tape the following day or the day after. I want the healing to have occurred. I use all dissolvable suture so that there is no problem or no pain upon removal of the suture. I, at day 6, remove the dressing, and then I gauge in a sense exactly when I'm going to follow them next, which is usually in a week or 2, depending on their signs and symptoms. If they have some soreness, which is sometimes very much expected, then I may see them sooner. If a patient has drains, I certainly see them the next day or the day after, because I want to see what the drain is producing, and I want to keep a very close eye. For some of my patients who are from out of town, they stay at the hotel or at friends and family nearby. I usually see them the next day or the following day just to make sure everything is sound, that everything is flowing nice and smooth. And then I usually see them 3 to 5 days thereafter, because usually that at that 5 to 7 day mark, the patients are off the antibiotics. I can gauge their chest, if anything bad has to happen, such as a hematoma, seroma, or whatever it may be, it would have had enough time to declare. And only when I do feel comfortable, I do send the patients out to fly back, be it the 5 day or the 7 day mark. There was one, and I always tell my patients to get insurance so that, for example, if they do have to cancel, they don't have to have the financial burden of paying a penalty, and that they just pay a nominal fee, $24, $37 or so, and that they, with a doctor's note, that able to change around the time. I send the patients out. I never send the patients out with a drain. I always remove the drain. I have heard stories from patients very clearly stating that there are some explant surgeons who basically let the patients go home and let their significant others or primary care doctors remove drains, which I find to be what I will clearly call malpractice. It is not fair for the patient or for the doc to be burdened into removing a drain, because the drain has a true purpose as to why it was placed. An exam is critical and only to be done by the plastic surgeon who placed it, or another plastic surgeon who is covering for the plastic surgeon, who understands, and that there is a discussion and a mutual talk as to why the drain was placed. I also have heard where patients are given medical advice within the office of the plastic surgeon by significant others or other members of the doctor's group who are not even medical professionals, who have no degree, and which I find to be very, very unprofessional and certainly a part of malpractice again. So going back to my patients, I follow up with them as needed accordingly, and for any emergent slash urgent questions or any visits that I find, my doors to my office are always open. They may wait a little, but they certainly will get seen whenever they want, the following day or the same night, pending whatever it may be. This is again just keeping a close tab. Other questions I've been asked over the break was the drain usage, and I use drains when there is a rupture, for example, of the silicone implant, if there is an abscess, or if I find there is an extensive dissection, for example, in a 750 cc implant. You can only imagine the dissection around and underneath that will cause, relatively speaking, more fluid or weepage because of the nature and extent of the dissection. I'll put a drain in, and if I'm ever sitting on the fence about putting a drain in, I will put one in, because I can certainly remove it. And usually when the output is 25 cc's or less, which is essentially 1/10 of a Coke can, as you can imagine, that's when I remove the drains, which I know that is relatively safe in the world of surgical world, that the fluid will eventually get pulled back and absorbed by the body, and it's certainly very safe. I always say and remind my patients, a drain will not prevent a hematoma. The hematoma will clot. It will not go through the drain. The only way to manage a hematoma, which is to proceed to the operating room and the surgeon removes, and majority of the times there is no frank bleeder, and usually this occurs in the first day or two after the surgery, which is usually what I would call a technical deficiency. Now, so basically that answers the questions in regards to my availability, and as far as my post-op follow-up. Again, I have a very close follow-up. I want to follow up all my patients in a very systematic way, and whenever they feel like they need to be followed up on. I've had patients just walk in, and certainly I've accommodated them because the ACE wrap was potentially a little bit too tight, or it moved up, or they did not get the garment, for example, fitting right, for whatever reason it may be, or they might have been nauseous, or if one medication works well for them or not. But majority of the times I'm able to talk to them on the phone for any emergency or any urgent reasons for the matter. So one of the other questions I did get asked over the break was, so I see, do you have hospital privileges? Absolutely. So I have, this is a message or a question from Miss Karen Watson. So I have privileges at Beaumont. I have also privileges at the Providence system. Normally, because I have my own operating room, I usually don't go to the hospitals. I don't take call, but at one hospital where I'm essentially forced to take call just because I'm affiliated with it, that's the way the structure has been set up. So I have affiliations with a total of 6 or 7 different hospitals, some of which I have let go because I've never been to that hospital. So one of the questions I did get asked over the break was, I have a cold. Is it safe for me to proceed with surgery? A cold is something that can certainly be very troubling. One can get like a lobular pneumonia. It can be a setup for a potential infection, especially when the surgery is being done right on the chest, which basically means that when the dissection, majority of the times the implant is placed underneath the muscle, which is the pectoralis, above the rib cage. And so the dissection is very tedious. It's very analogous to like a fall on a chest where you have some bruising of the rib. And if you can imagine, if you have that, and especially plus a cold, you're only going to confound and basically cause obstructive or airflow from within the lungs and out, which is not going to be set up. So the cold, along with the bruising of the chest, will cause breathing that's not going to be optimal and may certainly even prolong or make the cold worse, which the body may be able to fight off. I always want my patients to be in the utmost best of health. Last month in December, I had a nice lady, super nice, and I have to say she truly comprehended breast implant illness like any patient would. She came in, she flew in from Texas. She flew in the following day. When I listened to her, she actually had expiratory wheeze. And for her own good and from the goodness of my heart, I actually ended up canceling her surgery. And I said, you're not optimal, to her surprise, even though she really wanted to. And she gave informed consent to proceed. And I said, it is not acceptable. It is not comfortable for me. And I actually aborted and canceled the surgery, and which she later was very much understanding and thankful. And again, this was all for the patient's good. I did call her primary care doctor in Texas and discuss at great length. We decided that she was going to see a pulmonologist given her underlying issues. And again, we needed her to be in optimal, safe health. I will not accept the fact that, one can just walk in and sign that she gives informed consent, that she's aware of the risk versus benefits. This is ultimately for the patient, but sometimes the patient does not know best. And again, this is all proceeding such that there is least amount of turbulence in the operating room and that there are no surprises, and that the case goes very nicely and smoothly. So the other question I got asked was, recently there's concern about, an increase in my prices, which is a very nominal increase. I operate out of a very reputable surgery center or a Quad SF certified facility, which has the right standard, the right equipment, optimal equipment. I have 3 autoclaves, standardized and very much state-of-the-art equipment, as good as it gets, high end. I would say better than the hospital, if I may. I have able to maintain the sterility, the standard, the quality of care. Some of my patients that have come who are familiar with and their families are involved with hospitals and have been to operating rooms clearly have very confidently stated that they feel more comfortable being operated on in my OR versus the hospital. There was a patient a couple of months ago who actually chose, despite the breast cancer, to pay out of pocket and be operated on, given her financial situation, in my operating room versus going to the hospital. For in the hospital, I have my own, for within my operating room, I have my own anesthesia team, my own registered nurse who's certified. I don't have a medical assistant recovering my patients. I have phenomenal anesthesia team members. registered nurse circulators. These are what you would call the squad nurses, which basically means that they respond to any traumatic emergencies, whatever, within the hospital, or what I would call the SWAT nurses. And they have all the experience and expertise in handling my patients with breast implant illness, amongst the many others that I do. And so I have a nice team of members who help me on a repeated basis, who understand my prejudices and my concerns on how I want to manage. Whereas at the hospital, I have a new anesthesiologist every single time, a new CRNA, I have a new circulator, a new assistant, and equipment that's almost always not what I want, just given the fact that how things flow. So having said that, there are costs that come. For example, the $14,000 autoclave that needs to be replaced, the added costs of the chemicals / the gases, amongst many different equipments that we use. So given all of that, for quality control, this is going to be passed on, and it's a nominal addition. What I find, and I say this very bluntly, not all the explant surgeons that I hear about and I see and read, and eventually the news trickles down not only to me but to the patients, is how can someone offer the same surgery for half the price, for example, $3,500, which I find extremely disturbing, because if I'm able to do, I want to know and I want to learn from that surgeon what he or she is doing different that I would want to take so that I can offer that service. My costs alone are more than what that amount is, very clearly. And I will tell you, what you see is what you get, what you spend is what you get. And I find that how one can, and if you see and read and look at the feedback from the patients, in 3 hours that patient is getting an end block and a lift for that price plus an added amount for the lift. You can only imagine the level and the quality of surgical expertise that this patient is going to get, where I can tell you with definitive, absolute certainty that the capsule is going to be left behind, because I can certainly remove the implant only in 30 minutes and be done with an operation in an hour and a half, which is unfortunately what's happening with the majority of these cases. So I find that disturbing and troubling, and these docs are unfortunately charging significantly less, and how they're able to justify and financially provide for a service. It is extremely important for the patient to be operated on in a reputable facility. There are many docs across the country who operate in non-certified facilities, certified facilities where there is no quality control. The risk of infection is certainly high. There is no appropriate ventilatory system. There is no appropriate post-op anesthesia care. There are medical assistants who are assisting in the operating room, and the standard of care is certainly not met, something that you would expect in a third world country, unfortunately. So I find it is very important that, given the costs, that the quality is maintained, and that the patient gets the service and the right surgery. And again, if I can summarize the gist of this conversation, that the patient get the right explantation, the right end block, that is 100% removal of the capsule, be it end block or a total capsulectomy. So I'm going to go ahead and start looking through the questions, and I'm going to go top down. So Veronica Simon says there is no guarantee for an end block. So that is correct. So and even in the best of the hands, Dr. Fang, Dr. Chan, and amongst the many others, end block essentially means that the entire capsule and the implant is removed as one system, such that there is no breaks, there is no disturbance of that internal contents of the capsule so that all of it is preserved, so that if there is a rupture of the implant within, it's not going to leak out onto the chest wall or to the cavity. And that if there is an abscess or whatever it may be, mold, that everything is contained within, and that there is no spillage ultimately of the silica within the chest wall, which is extremely hard to remove. 100% or total capsulectomy, capsule means the capsule, ectomy means removal, is removal of the implant, and then later on the doc or the plastic surgeon removes the capsule and completely removes it in its entirety. But if there is a spillage of that implant, it certainly will spread into the chest wall. So that is what I would call not the gold standard, but ultimately the end block is certainly the gold standard, because you're preserving whatever the internal contents are, and that you're not allowing for any spillage or any fluid or whatever it may be within. And this is why taking your time and the 4 hours that I commit every patient to is key, and not rushing it and finishing an end block in an hour and a half or 2 hours along with a lift, which is 100%, I will say, unacceptable. So the next question from Mary Jane Beeman is, if it sticks to the ribs, does cauterizing work? I kind of answered that earlier. When you cauterize, you essentially burn. Now there might be some more residual, whatever it may be, that capsule, that thick capsule that I try to tear and pull apart, which I cannot. You will inevitably leave that behind. So what's going to happen is that cauterized tissue, the dead scar tissue, is going to fall off, and that continued silica will continue to impart that immune response. So I will tell you with definitive certainty that capsule needs to be removed, dissected off of the chest wall, such that the fascia, again, such that the fascia of the rib, the intercostal muscle, is pulled off of the muscle, such that you leave none of that capsule behind. And this is why that part of the surgery is the most critical. If your surgeon says 90% of it was removed, but that 10%, that was that disservice that was caused, and that 10% needs to be certainly also removed. So how can we be sure? Otherwise my capsule was took out separate. That's the word and honor, integrity, and the discipline of the surgeon, that they need to owe up. The picture of the chest wall is again key to show and document that the entirety of the capsule was removed. So 800cc requires what length of incision? So if you can imagine, if you have an 800cc implant and you lay it down and it has a capsule around it, what's the diameter of that implant? And that is approximately what I would do. I have seen videos of surgeons where they're trying to squeeze an implant out through like a 5 or 6 centimeter in an effort to make the incision small, and they try to fight and squeeze and wrestle that implant out. And I will tell you that is wrong. For if there is spillage, you may rupture that within the chest wall. Just make the incision bigger. That extra 2 or 3 centimeters will allow for justice to the tissue. You don't want to butcher, or you don't want to harm. You want to handle the skin in a very delicate way. Make the incision big, close, take the incision and close it such that it is a very nice aesthetic incision that will close ultimately at the inframammary fold, at the inferior aspect of the breast, so that ultimately it will not show. And this is an area where even if you have to look, you have to bend down and look, because this is where the scar is going to be hidden, and that allows for an excellent access where none of the tissue is essentially compromised. And the way I like to do my dissection, this is true for any of the plastic surgeons who are watching and any of the students, I like to proceed at the inframammary fold on the breast tissue, not on the chest wall, and I dissect and directly identify, dissect deep and identify the capsule of the implant. Once I have done that, I essentially ride the capsule such that I'm dissecting superiorly, laterally, medially, posteriorly, and I dissect in the path of least resistance. Sometimes I dissect top down, bottom up, laterally, whatever I find from my experience, whichever one is easiest, taking my time, not rushing it in the avascular plane. That way I disrupt the least amount of tissue. I saw a video once that one of my patients brought to me where one of the patients was being operated on. The breast plastic surgeon was dissecting around the nipple and going deep and literally through a 3 centimeter incision trying to wrestle this implant out right here in town. And I found that to be very disturbing, and certainly the patient, who is not a clinician or a physician and not even in medicine, she found that to be odd as to why the plastic surgeon would do this. Now I find essentially 4 different faults with that type of incision around the nipple areola. Number 1, you have put a scar right in the center of the chest. Number 2, you have altered and essentially compromised the nerves to the nipple, which certainly is an important aspect to maintain and not compromise. Number 3, the ducts themselves that you cut through around the nipple areola are not clean. They are essentially colonized with bacteria, just like any ducts are. And when you do dissect through and you go inferiorly, you may potentially contaminate, cross-contaminate the cavity within the chest wall that will eventually be void. And so you leave potentially the burden for that cavity to get colonized with bacteria. And 4, you're actually dissecting through the nipple, through the breast tissue, through the muscle, and then ultimately going below the muscle into the chest wall and cutting through the breast parenchyma, the breast tissue itself. And said that why disturb native breast tissue? Number 1. Number 2, that will cause scarring of the breast tissue itself, let alone disturb any of the ductules, whatnot else. So if the patient wants to breastfeed or whatever it may be, it may compromise some of the ducts that will be cut through inevitably to get through down to the lower level of the chest underneath the muscle. So now you have disrupted all this normal tissue, and let alone next year or the year after, when the patient, or several years later, depending on the age of the patient, when the patient gets a mammogram, it may identify scar tissue or fatty or breast tissue necrosis, which may ultimately inevitably lead to an unnecessary biopsy. So I say the best approach is the inframammary approach, where you have a nice window of opportunity to go in where a scar is not going to be seen, and you're able to very nicely, clearly write an implant through a relatively wide incision, which not many or anyone is going to see. And even when I see the incisions, I have to actually lift and bend in order to truly see the incision. I'm looking at the next question. So having the implant above the muscle is relatively easy because the dissection is not off of the chest wall, it is above the pectoralis, and what is in between the breast tissue and also in between the pectoralis. So the recovery is better because the dissection is not carried off of the chest wall, and not only the dissection does not allow dissection of the muscle itself in and around. So the dissection is off. So the recovery is better and faster. So you will see one of my patients who was on TV with me, she was able to come on and able to drive and kind of be much more as far as recovery wise. She had an expedited recovery as a result for that matter. And the next question, I just had an MRI, and the MRI suggests that I have an intracapsular rupture silicone. My implant is above the muscle. Do you think my surgery would be shorter in time? Yes. So I will tell you, because it's an intracapsular rupture, and again, sometimes looking at the MRI, and this was one of the other questions that were asked over the break, an MRI can be read as a normal MRI, and like one of the other many plastic surgeons have documented and said, and I attest to that, you could have a rupture that was not picked up by the MRI. So the MRI, even though that's the gold standard for picking up any ruptures, which picks up on what is called the Linguini sign, which is a rupture of an implant, it may not show a rupture, but in reality, it might be a rupture when the dissection is carried out in the operating room. Having said that, you cannot gauge and look at an MRI and say, well, the surgery is going to be easy or hard. Uh, the only few times where I can say that is if someone has a capsular contracture, which means hardening and thickening of the capsule, where the capsule becomes so hard it becomes rock-like, what they call grade 3 or grade 4, where there is grade 4 contracture, which I want you to look up if you could under Google, what they call Baker's classification, grade 1, grade 2, grade 3, and grade 4. Grade 4 being the most involved, where you actually have a distortion of the chest wall, and you also have pain at rest given the distortion as a result of the contracture. And so that dissection is relatively easy because of the fact that it is hard, and you can imagine you're dissecting off like a orange, lack of a better example, where the dissection is relatively hard and you're able to dissect very easily around. So those dissections are relatively easy. But for someone to have an intercapsular, that is within the capsule rupture, that certainly will be contained. So in that case, the end block is key, because if there is an intercapsular rupture, chances are there might be a extracapsular rupture, meaning outside of the capsule. And we're talking about the capsule of the implant itself. So that's why, and to answer the question, it is hard for me or a plastic surgeon to gauge and looking at an MRI and saying, well, the surgery is going to be easy or hard if the implant is ruptured or not, because of the nature of the dissection off of the muscle, which is above, because it truly could be adherent in the connective tissue that forms around. So one patient that had implants that were inserted in 1981, those were very hard because, as you can imagine, over the years, the implants had changed, distorted their shape, and they were adherent, and the connective tissue had formed, and the pattern of the implant had changed. This is one of the pictures that I put up, and I'm going to start putting up more and more pictures. So looking and gauging at an MRI, it's hard to predict what and how and what the intensity of the dissection is going to be. The next question is, there's blood work to see if possibly I have cancer associated with the textured implants. So if there is cancer, you're going to find that the lymph nodes are going to light up, not only in the axilla, elsewhere. Yes, ultimately, there are other imaging modalities that can be done that will show, for example, fine needle aspiration or lymph node biopsy, that will be a better indicator of this potential BII ALCL, which is the breast implant associated anaplastic large cell lymphoma. The other thing that can be done is to find any potential fluid in and around the breast implant capsule, in and around, that certainly warrants an aspiration to be sent to the cytologist so that they can look at the CD30 and other parameters, where the medical oncologist gets involved along with the pathologist, and they aggressively seek and rule out the malignancy. Also, MRI would inevitably be done in order to conclude that. And again, BIA-ALCL is rare, but again, it is certainly a very much recognized entity, to the point where in May of last year, I believe May of last year, 2019, France did step up and ban the textured implants, and hence there was a recall ultimately here, where textured implants are essentially off the shelf. Are drains a must? Do you always use drains? So I answered that question. I'll answer it again. Drains are not a must. There are docs, unfortunately, I have heard, regardless, who commit a patient to 2 weeks of drains. I find that wrong. Even on patients who have had an abdominoplasty, I'm taking the 2 drains that I usually put, one drain by 2 days, and usually the second drain by 5 to 7 days, depending on what the output is. And if they're less than 25 cc's or so, I remove the drains at that time if I do place them. If the dissection is done right and there is blood loss less than 2 or 3 cc's, then I find that the dissection went very nicely and very meticulously. I feel comfortable using my sixth sense and my judgment. I don't put in drains because I know that fluid is, and that muscle or that capsule which there is none remaining, is not going to weep. I find some surgeons put in drains just because they, lack of a better word, dig into the muscle. They hurt the muscle. They cauterize the muscle, or their pattern of dissection is not nice, or they leave the capsule behind, and as a result the body continues to weep, and they find that the drain is, in their practice, a required modality so as to allow for no collection. In my patients, well over 95% of the patients with certainty, and as you will see them attest, they have not had the need for drains. Do drains better help the skin to return to normal? No. What I find, if there's not going to be much drainage, remember, a small amount of drainage is certainly going to occur, but the body itself will allow it. If there are a lot of shear forces that cause the movement of the chest up and down because the patient is not wearing a nice stable garment, I find that, just like an abdominoplasty patient, that will also lead to more fluid accumulating that ultimately may lead to a seroma. This is certainly inflamed tissue, which is not healthy. It is the level of dissection certainly needs to be optimal so that the drains are not required. So the next question from Debbie Rivas is the procedure still around 4 hours for a double mastectomy going flat? I am worried about the pain upon waking up since right side is contracted, and making sure silica is off the ribs. So I will tell you, still the 4 hours. Now, a mastectomy patient is actually an easier patient for two reasons. Number one, almost always the nipple is gone in the center of the chest. The skin is nice and relatively on the flat side with the dome shape. Usually a tissue expander has been placed. And so what happens next is, we know there is no breast tissue, and there is essentially what will remain at the end after explantation is the skin and essentially the muscle and the chest wall, with no breast parenchyma and no implant and no capsule. So the dissection is easy because it's right in the center of the chest, and one only needs to utilize the same incision because there is no indication or reason to do another incision. Normally what I do is I make an elliptical type of incision right in the center so as to remove that redundant skin, and then I send that mastectomy scar off for analysis just to be absolutely certain that there is no residual cancer or whatever it may be that might be indolent. So I send that off to pathology, and that I contour the chest so that that's going to be ultimately flat chested, so we don't want a redundancy of the skin, so that it's essentially the nice flat chest that the patient ultimately chooses. Now, if the patient wants to, and this is where, if the patient is a right candidate, and if the patient is accepting of the risk versus benefits, what they call a DIEP flap, which is the deep inferior epigastric artery flap, where the patient essentially has a microsurgeon take the abdominal tissue with its the flap and essentially take it from the belly, and then they put it up, and it's the patient's own native tissue. It's a lengthy operation, 6 to 8, 10, 12, 14, 18 hours, depending on the level and complexity of the vessels that need to be attached. They can ultimately be candidates of that, but this is something that is the patient has to do their due diligence and talk to their respective microplastic surgeon who can offer them this the latissimus flap, again using the same native muscle, again another way to add volume to the chest, where ultimately, if done right, the muscle does not atrophy and the patient continues to preserve the volume. And again, involved operation, which I will say needs to be done at a later time once the patient has healed, because ultimately, when I tell all my patients, the goal of the operation is one, and don't complicate the surgery. The goal of the operation is, you have the 4 hours. This is outpatient surgery across the nation. Go in, do the right surgery, which is remove the implant plus the capsule and block, and get right out of Dodge. No more extra, no second surgery. Don't make 2 surgeries into one and complicate the recovery. The goal is to have a nice, disciplined, sincere, honest, motivated, dedicated, thoughtful dissection of the capsule off of the chest wall, and to dissect this capsule along with the implant and block preferably, such that the entire capsule is removed and the patient is given the due diligence and the chance to heal beautifully and let them recover from their breast implant illness, and then come another day, return if needed, if at all, to the operating room table to offer them the reconstruction if they choose to desire, using their own native tissue, if at all. And I will tell you, for me as a plastic surgeon, again, it all boils down to personality based. If someone is a minimalist, someone wants to pursue, someone is a risk taker, someone is willing to accept once they get a informed consent about what and how they're going to proceed with the surgery. Next question. My surgeon would not do any of that. I think it's different in the UK. I will tell you, at the end of the day, you go to China, you go to UK, you go to Brazil, you go to the US. We all are human. We all have the same anatomy and we have the same physiology. An implant placed in UK is the same implant reaction in the United States. We all are human, we all are alike, we all feel the pain. And for someone to say to leave the capsule behind, I will say this with definitive certainty, it is wrong medicine, bad medicine. There are a lot of explants now being done in 2019, much more than were done in 18 and 17, and I will tell you 2020 is the year of the change. I just heard about the Breast Implant Illness Awareness Day. Absolutely, I'm 100% for it. We need to have more and more discussion, healthy discussions just like this one. We need to have more plastic surgeons talking. We need to help more of the patients. We need to recognize this and establish this as an ICD-10 code. We need to have more of the administrative societies and bodies like the FDA, the CDC, amongst the many other societies, to recognize this entity and to honor it, to respect the patients. We need to have the manufacturers step up, and ultimately we need to have the insurance companies help the patients so that they can, just like in the 90s where they stepped up and offered, along with the manufacturers, the patients, especially the ones with the textured implants, the honor and the respect of having them removed by them providing the funding and not the patients, because it is ultimately a cancer-causing agent, which is not safe, and it is wrong for them to accept the fact that textured implants in the body are okay, but we're not going to sell them back to the patients now no more, ever since France stepped up. And again, good for France that they were the leaders in this world of banning the textured implants, where unfortunately the United States was not at its forefront and claiming the leadership, which we are doing our due diligence to essentially not only make the US but essentially the world a better place and a safer and a healthier place for our patients. So to answer your question, the capsule along with the implant needs to be removed. If the capsule is not removed, your surgeon is doing you a disservice, period. You need to find yourself a surgeon that you have comfort in, you have confidence in, you can talk to, that you have a dialogue, you have an honest, respectful conversation where there is a dialogue between you, and that you understand what are the risks versus benefits and indications of the surgery, and most importantly, how the surgeon views the breast implant illness. If your surgeon does not believe in breast implant illness, you can rest assured the capsule will be left behind, because they're not going to burden themselves with the task of removing the capsule. One free soldier is better than 10 hired ones. I'm not going to fight for my heart if I don't believe in a cause. I'm not going to be up till 2 in the morning working hard for a cause if I don't believe in it, and it's as simple as that. I had my implants removed in 1993. I never got much better. I recently learned my doctor left 2 pieces of the capsule in one breast. No explanation whatsoever. And I'll tell you, and I say this with certainty, and please, I want my patients, other patients, whoever it may be, to comment. If you were to walk into any plastic surgeon's office now, board certified plastic surgeon, and I want everyone and each and everyone who's listening to share this with everyone who is not. You have to go to a reputable plastic surgeon who is ASPS, American Society of Plastic Surgery, board certified, where they have that O sign, that circle. If you don't, you're getting a compromised care 100%. So that's very important. You can go to my website or the other websites and you can see exactly what I'm talking about. Almost all the surgeons, if not 100%, all of them will go ahead and remove the implant and leave the capsule behind, because this is unfortunately what was and what is and continues to be the accepted thought process. And I initially, when I was in training, I was under the understanding of as such, where the capsule will ultimately be absorbed and the body itself will break it down, which is certainly not the case. How can silica, as you can see that post that I put, be absorbed by the body? Because it continues to stay and it will continue to haunt and harm and trigger the body with the immune response. And I realized, and I continue to practice and preach, that the removal of the capsule is key. And certainly it is a tedious, meticulous operation, and it certainly comes at its risks, and it certainly comes with a expertise that only a few plastic surgeons can present and do. I say this with confidence, and one must feel comfortable operating in and around the chest, which basically means that ultimately the question becomes, how comfortable does your plastic surgeon feel in regards to putting in a chest tube, which basically means if the chest wall is unfortunately punctured in the nature of the dissection, and which is why everyone is, including myself, challenged by the operation where the capsule is removed. And if there is a pneumothorax, the plastic surgeon must feel comfortable, confident, and be prepared right on the spot within that 15-30 seconds to put in a chest tube and put it to wall suction, so as to allow for physiologic air and repair of that penetration into the chest lung space. And it is important for that plastic surgeon to have that training and to have the equipment and to have that expertise, so it's that the patient is able to be maintained into what would be a setting such that that potential emergency management is going to be delivered in a very efficient manner, not only by the surgeon but also by the anesthesia team member, and ultimately dictated by the leadership and expertise of the surgeon. So placing a chest tube, not everyone can do, especially docs who are not board certified or who don't feel comfortable, who have not placed chest tubes given their level of training. And there are many of us and given our level of expertise and comfort level as to how and what level of training that they have in regards to putting in a chest tube. So in summary, the dissection of the chest wall is very tricky. If the worst case scenario, one of the major complications that can arise, which is why almost all the docs are challenged by this operation, is the placement of the chest tube in the event of a pneumothorax, which is air within the lung. When the lung space is punctured, the intubation by an anesthesia team member, the placement of the chest tube, the proficient delivery of care such that the physiologic lung compromise is preserved, that ultimately dictates how comfortable the patient is taken care of. So if a surgeon A does not feel comfortable putting in a chest tube, and if they're operating in a facility where a thoracic surgeon or a general surgeon or another surgeon is not able to put in a chest tube emergently, they will never risk it. And that's why they will take their ease and say, well, I'll leave the 10% of the capsule behind on the chest wall and I'm going to walk away not sweating it. Versus the second surgeon who believes in breast implant illness wholeheartedly and says, I'm committed to, devoted to, And yes, worst case scenario, if the chest tube does arrive, I will put it in and I'll safely rescue the patient, because I want this patient to bounce back 100%, not 70, 60, or not continue to be burdened by the breast implant illness. So essentially what I will say, and what you have heard, is some docs have removed the capsules partially. Unfortunately, the patients now have had to go out of state to another group of docs, or a doc who will go back in and then remove the residual capsule. As you can see, the capsules are thick. They are very involved tissue, where, as you can see, I have tried so many times to tear or rip them. Even when I do cut through them, you can actually hear them being cut. And that tissue certainly will not go away in a matter of 3 or 6 months. It certainly will continue to persist, because it is very hard, thick tissue. And these patients inevitably, unfortunately, if they have to bounce back and they have to undergo a second set of surgery in order to remove the capsules the second time around, definitively, absolutely, with certainty. So tell us how you do a complete capsulectomy without end block when it is all intact. So that is, so this is what happens when you are dissecting end block. The entire implant plus the capsule is preserved. That's the end block. If you're dissecting and somehow you inevitably, let's say, puncture the capsule, which can happen because of how adherent the tissue is on the muscle or on the chest wall, then there's a small break in the capsule. So by definition, then that becomes non-end block, because now there is a window where the implant is now potentially exposed through that window to the outside. But nonetheless, you're removing the entire capsule, and in this case, if the implant is a saline implant, then you know it's not ruptured, or if there is a silicone implant which is not ruptured. So you can certainly, with good reassurance, in a non-abscess, non-ruptured saline implant or a silicone implant which is not ruptured, remove the whole implant plus capsule. The problem arises when the silicone implant is ruptured, or there is very rare mold, which mold does not grow within the chest because of the nature of the way the mold grows. So it's very rare to find. You don't want any potential spillage. And as you will see, you know, one of the documentaries that was done last month, which is going to be published, and basically shown, I did a end block which was taped live. I did the right side, which was a ruptured implant, removed end block, and so was the left. But there was no spillage because it was done end block. And I did not know that the implant was ruptured till the implant was removed in its entirety. And so there was no spillage of any silicone within the chest itself. And as a result, there was no need for a drain, and there was no need for any post-op different management. And this is why end block is key. Now, I will tell you, the best of the hands, the best of the surgeons, I explained, they will say end block cannot be achieved 100% of the time, just because of the nature of the dissection or the contour or whatever it may be. But the capsule needs to be removed such that the burden is removed in its entirety 100%. And the end block can be achieved in a very safe way if done in a very delicate, very nice, systematic, thoughtful way. And that's why whenever I board the patients, I board for 4 hours. There are times when I've done the surgery and I've taken 5.5 hours, because I take my time and I know the next patient is waiting, but they will be very much respectful and understanding of the fact that just like in their surgery, I'm not going to rush it. And whatever time I finish, I will take my time. And I've done explants where I've started my day and I didn't finish till 10 o'clock that night, just because of the nature of the dissection. The next question, I have had my saline implants for 20 years. They're very hard. So just from from what I've heard there, you most likely have a capsular contracture. This is the Baker's classification. My symptoms started about 2 years after the implants. 5 years ago, I was diagnosed with PSAs and currently on Remicade infusions. I really think of a lot of my symptoms are caused from the BII. Would you consider seeing me as a patient or for explant? Now, I will tell you, the most important thing here is I tell my patients, like today, I asked the patient what are the likelihood, or the one patient that I operated on yesterday who was going to be my guest, what is the likelihood you have breast implant illness? And she's the one who bounced off just within the 18 or 20 hours after the surgery, where she was saying, I feel so much better, my brain fog, my joint pains have improved. I will tell you, I tell my patients, only time will be witness and attest to the fact how involved and seriously ill you were, because there are many patients who have other issues going on, like arthritic issues or joint pain or the signs symptoms of dementia, whatever it may be, anxiety or underlying issues. We know this for a fact, 100%. There's no questions asked. Breast implant illness exists. Look at the tens of thousands of people who have bounced back and dramatically removed. Like one of my guests, Alicia, who was on, or Cheryl, who was on, who said, when I asked them on the spot, when I did the Facebook Live with them, do you think this is a placebo effect? And she said, well, I wish I would placebo my effect and myself 10 years, 100,000 times, whenever I could possibly do, because I would have done it. And the only difference between then and the last was the fact that my implants are out. And the bottom line is, only when you get the implants out and when you have your surgery done right, and you know with certainty that the capsules are removed, then let time declare and attest to the fact that these were the implants definitively and not anything else. Because there are patients that I've operated on with rheumatoid arthritis that have been on prednisone, that have been on these infusions, and amongst the many other problems that they come in with. And I tell them no guarantees. Only after the implants will we know what type of effect. Were they compounding your illness? Were they making your matter worse? Or like today, I saw a patient who is currently in the process of being diagnosed with MS. They're not absolutely certain. She's about to get her MRI of the head. I just saw her today in clinic, and the question was, should I get started on these multiple sclerosis MS medication? Should I wait for the explantation? And I said, I cannot promise anything except for the fact that you certainly could have MS on top of the BII, and I'm not going to make any commitment or a determination except for the fact that the breast implants are not causing you any good. If anything, absolute certainty they're causing you harm. And if you get them out of the equation, we will see how you bounce back. And I will tell each and every one of you, and to share this, never accept a compromise in your capsulectomies, which means you want to get the right surgery. You don't want to be in a situation where you've had the surgery, you've invested your money, and the next thing you know, you are now in that situation. Like that other question asked, I had my explantation done, but the residual capsule was left behind, and that you only bounced back 50, 70, 90%, and now you're continuing to be haunted by the same capsules that need to now be removed with certainty, because we know once the capsules are removed, the patients bounce back one after another, and literally in the thousands and thousands. So absolutely, you need to do a national conference for explant procedure. I will tell you, Mary Jane Beeman, you're absolutely right. I invite Dr. Feng, Dr. Chan, all the sincere, honest, honorable explant surgeons who only explant, who are explanting in a very proficient and a professional way, who are not doing explants and a lift in 2 hours like some of the explant surgeons are claiming to be, who to come on and to come up with a consensus, to come up with an understanding, to share patient data, which I will be more than happy to, so that we can learn, define, and hopefully teach not only the plastic surgeons here in the US, Canada, but across the world, and to set up a standard and to set up a right way of dealing and diagnosing and tackling this mysterious, lack of a better word, with quotes, illness. Look, right here in town, a couple months ago, was a young lady in her mid-30s, and the entire department of this major hospital system in the US, a major hospital system, they were not accepting of the fact of what breast implant illness is. They did not want to acknowledge the fact. They could not imagine that that would be an issue. I do not know what and how and what it will take for them, but it was not only but the family member who was persistent and was adamant about having the surgery done right. And slowly but surely we will see and define that, you know, the implants and the capsules need to be removed in its entirety. And this is the post that I put out earlier, where you see the polarizable light consistent with silica. You don't want to leave the silica behind. If anything, that is the ultimate of hard evidence and proof that the implants and the capsules need to be removed. Could cold laser be used to help the healing? Laser is not ideal, and when I use the word healing, I do not understand exactly what the question is. Is it after the explantation, or is it to remove the laser, to use the laser to burn the capsule? I think physically you have to remove the silica. This is similar to the silica dioxide, obviously the metal toxicities, whatnot else, what silica is made up of, the silicone gel. And we do not want to burn, because what you're doing is essentially breaking it down. It might break up into small pieces and then eventually get absorbed more. And again, I'm not an expert in this cold laser, so I'm going to hold off on making any intellectual or any anecdotal or any guesses there. I think more research needs to be done there. The next question here I have is, if you are wrapped after surgery, when do you take a shower? So that's a good question. So normally when I close, I do a 3-layer closure. I use the vicryl suture on the deepermost, then I use the monocryl suture on the second, or what you call the intermediate layer, which holds the dermis together, and then epidermal suture, which is the monocryl that I weave like at the very surface. So that reinforces that inframammary fold. Now then I put the tape / the steri strips to hold the suture and to take the tension off. Now normally the skin takes 2 to 3 days to become watertight. So the water tightness is maintained, and this is why I say, unless there is a problem or an issue and the patients have full access to my cell phone, if they for whatever reason want to be seen sooner, I see them, but I don't want to see them till day 6, because I'm not going to remove the dressing, I'm not going to do anything, and I feel very comfortable. If I ever feel uncomfortable, meaning how the dissection went or how the surgery proceeded, I always see them the next day. I had one of my patients who lived just 45 minutes. I said, you need to stay here because I want to see you back, and you might as well stay at the hotel, which is right across, because I want to see you first thing in the morning. Just in case there's anything, whatever it may need to be, I can do it, or provide making sure that the pain level is controlled optimally, or if there's any issue, the patient is right across. And remember, this is relatively involved surgery. There is no such thing as a surgeon who does not have complications. There is no such thing as a surgeon who has perfect records. If that surgeon is there, then either of two things. Number one, he's not telling the truth, and number two, he's not operating. So going back to, I always want the patients to come day 6. So now this is double the time. The skin is essentially sealed, closed shut. And then that's when I have my patients take a shower, so that when they do have the tape removed and they take a shower, the water does not trickle into potentially the cavity. And the water is smart. It will find a way to go in. And wherever there is water, there is bacteria. So I always say, let the skin heal, let the incision heal. And when the time is right at day 6, I let you take a shower, so that now you can, with confidence, allow for the water to go in, because we don't want the water to kind of hide in the crease or in between the tape and the suture. and so as to allow for potential seepage or a capillary refill of whatever it may be, a communication between the in and out. So by usually day 5, 6, or 7, the skin is super tight, nice closed, and it is nice and safe for the patient to take a shower safely. Should you detox before surgery? Now, this is a very important question. What is the ultimate detox? Number one, I don't want any of my patients to be taking any of the supplements. I find that the supplements in it are not regulated. They're majority of them made overseas. They are not regulated. They don't have a defined component. They're not optimized. One packet might be different from another batch because, again, there is no tight control. I find patients taking chelating agents. Ultimately, the best detox is to remove the capsule off of the chest wall or off of the patient's body. And that is the ultimate of the detoxing that can be done, which is at the time of surgery. The best thing before is absolutely stop smoking. Smoking is not good for you to begin with. It certainly compromises the wound healing. Number two, eating healthy, making sure that you're eating non-organic and just the usual well-rounded diet with all the vitamins and vitamin C, but not supplementing with any of these over-the-counter or herbal medication, because you will find that there are different components, exaggerated components, or components that are not even listed what are supposed to be, just given the nature of the way these are marketed and sold. So I suggest that the detox that you will do is just to be well read, to make sure that you find a surgeon that will completely remove and confirm that they will remove the capsule, because that will ensure that you will bounce back and you have given your body a fair chance. I will state this with definitive certainty. I can only do so many of these surgeries in a year. I am relatively very busy. I've had a very busy practice from the first week I started my practice. And thank God I'm doing very well. What I want to do is, using this modality, the Facebook, every couple of weeks. Hopefully the next session I will have is going to be on Monday the 13th, where I will hope to have my friend, my patient, who I just operated on yesterday. She can share her experience that just within 24 hours, we can have a patient come on Facebook Live and comment and state how well and how good they feel, just immediate post-op, where they should be hurting, and essentially, given the nature and the level of the dissection, essentially be recovering in the post-operative phase. So we will see how Heidi is going to be able to share with her own words, her own experience, so that we can learn off of her and we can help the other many patients understand this breast implant illness better. The best detoxification is to basically do the capsule in its entirety, remove it, and to ensure that a surgeon removes the capsule in its entirety definitively with pure confidence. The next question is, can you recommend a compression band? Now, I will tell you, I posted another picture of another band or garment that is very important, because once the patient is done and the surgery is carried out in a nice, efficient way, there's a big cavity, roughly 325, 375 cc's that the implant on average is, along with the volume of the capsule that's removed. We don't want any shear forces that are going to cause that up and down movement that will prolong the recovery. I want a garment that's going to hold the chest nice and tight, cause a compression, and not only that, but also cause a nice recoil or a lift, so that when the patient turns around, twists in bed, or gets up to go to the bathroom at 2 in the morning, the same day, we don't want shear forces, but kind of like a nice, lack of a better word, a bulletproof vest. Not uncomfortable, but tight enough such that it's holding you snug. And so the picture that I put up, I like that picture for two reasons. Number one, you have an adjustment on the shoulder. It's relatively wide. It's not going to hurt the shoulder. Also, the waist is stable. And then there are different levels or grooves that you can put the clips on, so that if you are medium, You can go a little bit wider, stronger, tight compression, so that when you twist and turn and move about, your chest is basically being held. It actually helps with the pain too. Now, speaking of pain, I just want to address, normally given every patient, I always go through this. If they can tolerate an non-steroidal, which is an anti-inflammatory, I usually like Aleve, 220 milligrams over the counter. It works for 12 hours. So you take one in the morning, one in the evening. So you have a good 12-hour control by this anti-inflammatory. Sometimes it works 20, 30, 40% very effectively. Someone has a broken rib, for example. In the world of trauma, we would always give the non-steroidals for patients who would be able to tolerate, because it is an excellent anti-inflammatory control of rib chest pain. Number two, Norco, I almost always write as like a strong medication. It has the codeine and a Tylenol in it. It's a combo drug. And what I find useful is the patients are able to take it. It works very effectively. It's given to patients usually who have, let's say, for example, orthopedic issues or major abdominal surgery, which really helps with the pain. And then number three, I give them tramadol. So between the Aleve, the Norco, which has the codeine and the Tylenol, and number three, the tramadol, the patients are able to work with these medications such that they have optimal control. They can get up and move about. I want them to take nice deep breathing exercises. When they walk, it helps with the circulation, it helps with the mentation, it helps with the recovery. And ultimately, when one walks, it really helps with the gut, the GI movement, where the Norco, for example, slows the gut down. Almost all the nausea causing pain medications, Norco, be it tramadol, whatnot else, the walking helps. And ultimately, the endorphins that are released from the muscles of the leg help with the optimal pain control. So I did post this one garment. You can get it off Amazon. Jennifer can send you the link if you text or email her tomorrow, and we'll certainly post this so you have that at your comfort. Now I'm going to go ahead and take one more question, and then we'll stop here just given the time of length. Please share this with everyone. Hopefully you found this very useful. If a lymph node is involved, do you recommend just removing the lymph node? Now, I say to you, I make an incision in the inframammary fold right here. The lymph nodes are right in the axilla. This is inflamed, angry tissue, which basically means that if there is any potential rash, inflammation, the lymph nodes are going to light up. For example, if I cut myself shaving, I used that example, you're going to find the next day the lymph nodes in the anterior neck and the posterior neck, ultimately, depending on the level of the cut, are going to be tender, sore, because my body is going to try to want to fight off what would potentially be an infection. Same thing on the chest in the patient who has inflamed, angry tissue, which is part of the breast implant illness, because not only you have the rash all over and amongst the many other problems that the breast implant illness patients have, you can have the lymph nodes in the axilla light up in a cyclic type of a nature. Now, always, 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 very important, 1 out of 8 or 9 women are going to get breast cancer. We must not be naive and say, well, it is not breast cancer. It is always in the equation on the differential. At the time of my surgery, I will not remove that lymph node because that might be reactionary. I always ask my patients, have you had a mammogram or an ultrasound or any other imaging modality? If they have a strong family history, I tell them to get genetic testing for breast cancer for the BRCA gene. If they have not had a mammogram, I tell them to get a mammogram because I don't want to be operating and running into any unexpected masses, which I certainly have run into. And if I do, I absolutely 110% sending off to pathology because it's cancer till proven otherwise. Remember, 1 out of 8 or 9 women are going to get breast cancer. So to answer the question, the lymph node, now there was a patient that came to me, and this is why the pre-op exam is key, and I find a lymph node. I always tell the patient, well, I'm not sure what this is, go see a breast surgeon. The breast surgeon may end up doing a mammogram / an ultrasound, maybe an MRI, to better define and see if this is something of significance or not. Sometimes they may want to remove a lymph node. as a separate procedure done as under local as an outpatient surgery, where they go in and remove the lymph node, send it off to see what it is. And there is no harm in doing it. And again, all being judged by the surgical oncologist / general surgeon. Now, if this lymph node comes and goes, or is in cyclical nature, or whatever it may be, or if it's been present for so many months, we always want to err on the side of being cautious, because breast implant illness surgery, or the explantation and block, is not emergent surgery. It is elective. So for that reason, I want to get the clearance on everyone. I want to be able to have whatever abnormal masses that there are be defined and explained, because the last thing I want on the operating room table is any turbulence, any surprises. I want smooth sailing. I want no rocky waters. I want everything to be nice and pristine so that I go with the flow. And so if there is a lymph node that's there, it is what I would call a smart, important, given the history and physical exam, to figure out what this lymph node is, because 1 out of 8 or 9 women, and again, just being the devil's advocate, potentially might get breast cancer, and we don't want to be potentially sitting on something that might be potentially malignant and lethal. So that when the surgery is done, that there is a plan and a plan of action. So I would leave it up to your surgical oncologist, primary care doc, to work that up, be it ultrasound, FNA, fine needle aspiration, be it a lymph node biopsy, which happens all the time. This certainly differential could be the BII, ALCL. You know, one has to keep that in mind, because the eyes don't see what the mind doesn't know. So I just heard, I received a quote last year. If you received a quote last year, you're good for it for this year, because I want to honor each and every single patient who was seen. And given the slight increase, just given the costs that have gone up this year, and unfortunately 3 years ago, 5 years ago, the costs were very different than what they were last year, and this year is certainly higher. The next... Okay, so so let me answer this question for Tammy Lee. I know I have to stop supplements. I do not want you to stop the hormone replacement drug. This is important. Sometimes the tamoxifen is given, sometimes the estrogen, progesterone is given. That is a important medical necessity dictated by the MD. So that is an important prescribed medication. When I say supplements means like the herbal medications. For example, any of these garlic or over-the-counter like fish oil, for example. Now I know fish oil is relatively safe, but I do not know, sometimes they have impurities or inaccurate ingredients mixed in along with the fish oil to kind of make it a combo drug. One patient was actually taking 20 of these, a bag full, and she had invested like literally thousands of dollars per month just taking those, thinking that the breast implant illness would subside. And I'll tell you, no matter what you do, that's not going to take the breast implant illness away. What is going to take the breast implant illness away is removing the implant plus the capsules. So having said that, I am going to continue on. I will join you folks next time on the 13th with my patient Heidi. I want you to please continue to ask questions. I will continue on. Hopefully you found this informative. Please share this with everyone. We want to make this a better and a healthier world. And if you can help one patient not implant, if you can help one patient explant well, we have certainly achieved the purpose. And I'm going to end with this very nice and pleasant and important phenomenon and thought, which is, we all live in a world where we make choices. We have feelings of remorse. You go buy a car, you go buy a house or a watch or a shoe or a cell phone, or you go on a vacation, or you go vote for someone given the elections that are coming up. You always walk away and you have a feeling of remorse. You have a feeling of that you did something wrong. You should not have invested in this. I will tell you, breast implant illness and explantation is such a phenomenon where almost 100% of my patients, with certainty, 100% of my patients who have explanted with me, or any of the patients on social media who have explanted, have never regretted removing the implants, number one. And number two, if anything, they said they wish they had not put in the implants. And number three, if at all, they wish they had removed it sooner, so that they would have bounced back to normalcy, and that they would have freed themselves of the misery of the breast implant illness. So having said that, thank you everyone for listening. Thanks for tuning in. Hopefully you found this informative, and please share and talk and discuss. The power of your words, the power of the discussion is intense, and it is the reason why we are going to bring about the change. The plastic surgeons, unfortunately, are not going to do it. The manufacturers absolutely will not. The FDA has not, and the patients certainly will, the fourth group. Take care, good night, and God bless everyone. Bye-bye.